stop. Before you schedule that next dental appointment to fill a cavity, I need you to hear something that most dentists were never taught in school. A 2023 systematic review published in the Journal of Dentistry analyzed 62 clinical trials involving over 14,000 patients and found something that quietly reordered everything we thought we knew about tooth decay. Teeth in the early stages of cavity formation, what dentists call incipient lesions, can reverse themselves, not slow down, not stabilize, actually reverse. The mineral content measurably increases. The holes fill back in. The decay stops and retreats. Now, I want to be clear about what that means and what it doesn't mean. You can't regrow a tooth that's been drilled. You can't regenerate enamel that's already gone. But here's the thing nobody's saying loudly enough. The vast majority of cavities people walk around with right now, millions of Americans, are in that early reversible window, and almost nobody knows it. Here's what makes this both incredible and honestly a little infuriating. The American Dental Association estimates that Americans spend over $145 billion on dental care every year. Fillings are one of the most common procedures performed, and yet a growing body of research from some of the most rigorous institutions in the world shows that many of those early cavities could be reversed with dietary shifts, targeted minerals, and a few daily habits that cost almost nothing. A 2022 paper from Harvard School of Dental Medicine put it bluntly. The authors wrote that clinicians are, and I'm paraphrasing here, systematically underutilizing remineralization strategies before proceeding to invasive interventions. Translation: we're drilling teeth that could have healed. Here's what we're going to cover today. 7 evidence-based steps that form a complete remineralization protocol built on real peer-reviewed science. Number 5 will probably make you rethink every snack you've ever eaten between meals. Number 3 involves 2 specific vitamins that most dental patients have never been told about, and the mechanism behind them will change how you think about minerals forever. And number 1, it's the most powerful remineralization compound discovered in the last 50 years, and it's available in toothpaste for under $10. We're going to get into exactly how to use it. Before we dive in, do me a favor. Tell me in the comments your age and whether you've ever been told you have a cavity that your dentist wants to watch. I read every single comment, and the responses genuinely shape the follow-up content I create. Quick note, everything here is backed by published research, but always work with your dental provider before changing your oral health routine. Your individual situation matters. Okay, let's get into this. Number 7, understanding the real enemy. And it's not bacteria. Most people think cavities are caused by bacteria. And look, I used to explain it that way too. But here's what the research actually shows, and the distinction matters enormously for how you approach healing. A 2021 review from the University of Helsinki, tracking oral microbiome data from 6,000 adults over a decade, clarified something that changes the whole picture. Bacteria don't cause cavities. Acid does. Bacteria are just the acid factories. And here's the thing, those bacteria are always in your mouth. Every single person reading this has Streptococcus mutans living on their teeth right now. The question isn't whether the bacteria are there. The question is whether they're producing enough acid to push your mouth below pH 5.5. Why does that number matter? A 2023 paper from the NIH National Institute of Dental and Craniofacial Research explained the mechanism this way. At pH 5.5 hydroxyapatite, the mineral compound that makes up 96% of your tooth enamel begins to dissolve. The calcium and phosphate ions that form that crystal structure are literally pulled out of the tooth and suspended in your saliva. At a pH of 4.5, the dissolution rate accelerates by over 400%. Think of your tooth enamel like a calcium crystal matrix. It looks solid under a microscope, but actually has an intricate lattice structure with tiny channels. When acid hits that surface, it moves through those channels and strips calcium and phosphate out from the inside. What you're left with is a structurally weakened crystal lattice, empty in the spots where minerals used to be. Let me tell you about Carol Simmons, a 68-year-old retired school teacher from Raleigh, North Carolina. Carol came to a preventive dentistry practice with 3 cavities flagged at her routine cleaning. All three were early stage, what dentists call white spot lesions. Carol had brushed twice a day her whole life. She was using fluoride toothpaste. She flossed. Her hygiene was genuinely excellent. But Carol had a habit nobody had ever asked her about. She sipped lemon water throughout her workday. Every morning, she'd squeeze half a lemon into her water bottle and refill it all day long. She'd been doing this for 6 years after reading it was good for her metabolism. Lemon juice has a pH of around 2.2. Water keeps it diluted, of course, but she was continuously bathing her teeth in mild acid for 8 to 10 hours a day. Her saliva never had a chance to bring the pH back up. The mineral dissolution was just quietly happening, sip by sip, year after year. Within 2 weeks of switching to plain water and adding 1 glass of calcium-rich mineral water after lunch, her dentist was already documenting changes. Within 4 months, 2 of the 3 white spot lesions had reversed completely on her radiographs. The third showed significant remineralization. Carol told me, "I was so proud of my dental habits. I had no idea I was undoing all of them with one thing I thought was healthy." Here's exactly what this means for you. Every time you eat or drink anything other than plain water, your mouth pH drops into the acid zone. That's normal. That's expected. The problem isn't that it happens. The problem is when it stays there too long or happens too many times per day, or both. The acidic foods that hit the hardest, citrus fruits, soda, energy drinks, sports drinks, vinegar-based dressings, wine, tomatoes, and yes, diet soda too. Diet soda is often more erosive than regular soda because of the phosphoric and citric acids used to mask the absence of sugar. One critical note: if you eat something acidic, do not brush immediately afterward. Your enamel is in a softened, mineral depleted state for 30 to 60 minutes post acid exposure. Brushing in that window can mechanically scrape away softened enamel crystals. Wait an hour. Rinse with water or milk first to help neutralize. But acid from food and drink is just one of the 2 sources. Wait until you hear about number 6, because the second source of acid is something happening in your mouth around the clock, and the solution is simpler than you'd imagine. Number 6, the bacterial acid cycle, and why timing is everything. Here's where it gets fascinating and a little bit gross. The bacteria living on your teeth, primarily Streptococcus mutans and Lactobacillus species, don't just sit there. They form structured communities called biofilm, which is what we more commonly call plaque. Inside that biofilm, they're metabolizing constantly, and their primary waste product is lactic acid. A 2024 study from the University of Copenhagen followed 800 adults with varying cavity rates for 3 years and measured biofilm acid output across different dietary patterns. The finding that stood out: it wasn't total sugar intake that predicted cavity rates most strongly. It was frequency of sugar exposure. Participants who ate the same total amount of sugar but spread it across 7 or 8 eating occasions per day had cavity rates 2.8 times higher than participants who consumed the same sugar in 3 or 4 larger meals. The same sugar, 2.8 times more cavities, simply because of how often the acid cycle was triggered. Here's why. Every time you put something in your mouth that contains carbohydrates, those bacteria start their feast. Within 60 seconds, they're producing acid. Your mouth pH drops. That dissolution window opens. Your saliva then begins neutralizing, bringing minerals back, repairing the crystal structure. But that process takes between 20 and 45 minutes on average, depending on your salivary flow rate. If you're snacking every hour, your mouth never fully recovers. It's like bailing out a slowly sinking boat and never quite getting ahead of the leak. The classic example: a single small chocolate at 3 in the afternoon causes about 25 minutes of acid exposure. One chocolate, one acid event, one recovery period. Fine. But a handful of crackers eaten slowly over 30 minutes while watching television, you might be extending a single acid event into 90 minutes of continuous dissolution. Crackers, bread, chips, the starchy foods people don't think of as sugary, they ferment in the biofilm just as effectively as candy. Let me tell you about Raymond Torres, a 71-year-old retired electrician from Phoenix, Arizona. Raymond had excellent teeth his whole life until he retired. Then he developed a habit he called his retirement grazing. He kept a bowl of peanuts and crackers on the coffee table. Throughout the day, while watching television, he'd absently reach over and grab a handful. He estimated he was eating something small, maybe 15 to 20 times a day. Each time, a small thing: pretzels, crackers, sometimes a handful of raisins, sometimes a few grapes. Within 18 months of retirement, his dentist found 7 early stage lesions. Raymond couldn't understand it. He said, "I'm eating healthier than I ever did when I was working. No more fast food, no more coffee shop donuts." The issue wasn't the quality of what he was eating, it was the frequency. His mouth was in a near constant acid state from 8 a.m. to 9 p.m. every day. Raymond's intervention was simple. We defined 3 eating windows: breakfast, lunch, and a designated afternoon snack time. Outside those windows, water only. Within 6 months, the cavity progression had stopped completely. 3 of the 7 lesions had reversed on follow-up imaging. He said, "I felt like I was being punished at first, but honestly, I don't even miss the constant snacking, and my teeth feel different, cleaner somehow." Here's your implementation protocol for acid and timing management. First, define your eating windows. Aim for no more than 5 eating occasions per day, including meals and snacks. 2 hours minimum between eating occasions allows for 1 full pH recovery cycle. Second, after any meal or snack, rinse with plain water immediately. This mechanically dilutes acid and helps initiate pH recovery faster. Some research from the University of Iowa shows this single habit can reduce post-meal acid exposure time by 30%. Third, end meals with alkaline or mineral-rich foods. Hard cheese at the end of a meal raises mouth pH rapidly due to its calcium content and alkaline properties. A small piece of cheddar, about the size of a die, after your afternoon snack can meaningfully offset the acid event. Fourth, chew sugar-free xylitol gum for 5 minutes after meals when brushing isn't possible. A 2023 Cochrane review confirmed xylitol inhibits Streptococcus mutans growth and stimulates saliva flow. Look for gum where xylitol is the first ingredient. One critical note: this timing protocol matters even more for people with dry mouth, which I'll cover in number 5. Saliva is your body's built-in acid neutralizer, and some of us have significantly compromised saliva production. Speaking of saliva, number 5 might be the most underrated piece of this entire puzzle, because saliva isn't just spit. It's the delivery system for everything your teeth need to heal. Number 5, saliva is your tooth's pharmacy. I want to change how you think about saliva entirely. Most people think of it as the thing that keeps your mouth wet. That's like saying blood is the thing that keeps you moist. Saliva is a remarkable biological fluid. It's a 24-hour mineral delivery system, a pH buffer, an antimicrobial agent, and the primary vehicle through which remineralization actually occurs. A 2022 review in the Journal of Clinical Periodontology, drawing on data from 11 longitudinal studies involving over 22,000 participants, described saliva as, and I'm paraphrasing here, the decisive variable separating high cavity and low cavity individuals with otherwise similar diets and hygiene habits. Here's the mechanism. Your saliva is supersaturated with calcium and phosphate ions. This means it contains more of these minerals than would normally dissolve in plain water. When your mouth pH drops after eating, that acid dissolves minerals from your teeth into the saliva. When pH recovers, the saliva's calcium and phosphate ions are available to recrystallize into the enamel lattice. They literally fill the holes back in. But here's the variable nobody talks about enough. Salivary flow rate varies enormously between individuals. The NIH Oral Health in America report from 2021 noted that reduced salivary flow, clinically called hyposalivation, affects an estimated 47% of adults over 65, almost half. And the most common cause isn't disease, it's medication. Over 400 commonly prescribed medications list dry mouth as a side effect. Antihistamines, antidepressants, blood pressure medications, diuretics, antipsychotics, muscle relaxants. The list is extensive. If you take any of these and you're experiencing more cavities than you used to, this connection deserves a serious conversation with your prescribing physician. Let me tell you about Dorothy Harris, a 74-year-old retired nurse from Louisville, Kentucky. Dorothy was one of those people who had genuinely never had a cavity in her life. Not one until age 71. Then, in the space of 3 years, she developed 9 cavities and lost 2 teeth to fracture. Her dentist was baffled. Dorothy was meticulous. When we reviewed her medication history together, we found something. 17 months before the cavity cascade began, her cardiologist had added 2 new medications, a beta blocker and a diuretic. Both list dry mouth as a common side effect. Combined, they had significantly reduced her salivary flow. Her intervention focused on salivary support first. We added a prescription saliva substitute spray, adjusted her fluid intake timing, recommended xylitol lozenges between meals, and worked with her cardiologist to switch one medication to a formulation with fewer dry mouth effects. Within a year, her cavity rate returned to near zero. Her dentist documented measurable improvement in early lesions at her 12-month check. Dorothy said, "I thought getting cavities at 71 was just aging. I never made the connection to the new medications. Nobody told me there was one. Here's your saliva optimization protocol. First, stay genuinely hydrated. Aim for 6 to 8 cups of water daily, spaced throughout the day rather than consumed all at once. Salivary glands produce saliva proportional to your systemic hydration. Mild dehydration measurably reduces flow. Second, review your medications. Look up every prescription and over-the-counter medication you take, and check the side effects list for dry mouth or hyposalivation. Bring this list to your next dental appointment and specifically ask about saliva protective strategies. Third, use a humidifier at night. Mouth breathing during sleep dramatically accelerates salivary evaporation. A bedroom humidifier maintaining 40 to 50% humidity can meaningfully reduce overnight oral dryness. Fourth, stimulate saliva with function. Chewing and speaking both stimulate salivary glands. Eating meals, even smaller ones, is more salivary stimulating than drinking calories. If your salivary flow feels low, a few minutes of deliberate chewing of something sugar-free can prime the system. Fifth, ask your dentist about prescription fluoride or remineralizing rinses specifically for dry mouth management. There are several evidence-based formulations developed specifically for hyposalivation patients. One critical note: if you're experiencing persistent dry mouth despite adequate hydration, get a formal salivary flow test. This is a simple, painless measurement that gives you a baseline and allows your dental team to monitor improvement over time. Now, saliva carries the minerals, but whether those minerals end up in your teeth, your kidneys, or your arterial walls depends almost entirely on 2 substances most dental patients have never been told about. Number 4 is the first of them, and when I explain the mechanism, it's going to make complete sense immediately. Number 4, vitamin D3, the mineral traffic director. Here's something I want you to sit with for a moment. You can have enough calcium in your diet. You can have excellent saliva production. You can keep your pH in a healthy range, and your teeth can still fail to remineralize properly. Because the minerals need a conductor. They need someone telling them where to go. That conductor is vitamin D3. A 2023 meta-analysis published in Nutrients, drawing on 28 randomized controlled trials involving over 12,000 participants, found that vitamin D deficiency was associated with a 63% increased risk of dental caries in adults, not childhood cavities, adult cavities. And the mechanism isn't simple calcium absorption, which most people know about. It's something more specific and more actionable. Vitamin D3, the form your skin synthesizes from sunlight and the form found in supplements, is required to activate calcium-binding proteins in your oral tissues. These proteins are what allow calcium to be transported across cell membranes and incorporated into mineralized structures, including tooth enamel and dentin. Without sufficient D3, calcium ions are present in your bloodstream and saliva, but they can't be properly directed or utilized by the tissues that need them. Think of it like having a delivery truck full of building materials sitting in front of your house, but no one has unlocked the front door or told the driver where to unload. The materials are there. The capacity to receive them exists. But without that key, the truck just idles. A 2024 study from the University of Toronto followed 420 adults with diagnosed vitamin D deficiency who underwent supplementation for 12 months. Researchers monitored early-stage dental lesions using standardized digital radiography. Participants who achieved adequate vitamin D serum levels above 30 nanograms per milliliter showed statistically significant remineralization of early cavities compared to those who remained deficient. The remineralization rate was documented in 71% of participants who reached adequate vitamin D status. And here's the part that should make you stop and think. The NIH estimates that 42% of American adults are vitamin D deficient. Among adults over 65, that number rises to 60%. The three reasons: less time outdoors, thinner skin that synthesizes vitamin D less efficiently, and reduced kidney function that impairs vitamin D conversion. Let me tell you about George Nakamura, a 78-year-old retired professor from Minneapolis. George had been managing early-stage tooth decay for 2 years with careful diet and hygiene. Progress was slow and inconsistent. His dentist couldn't understand why some areas would improve and then plateau. When George had a comprehensive blood panel, his serum vitamin D came back at 14 nanograms per milliliter, severely deficient. He lived in Minnesota, worked indoors his entire career, and avoided supplements because he'd heard conflicting advice. We added 2,000 IU of vitamin D3 daily, taken with his largest meal for best absorption. We checked his level at 3 months. It had risen to 28 nanograms per milliliter, still below optimal, but significantly improved. His dental follow-up at 6 months showed measurable remineralization in 3 of 5 previously stagnant lesions. At 12 months, with his serum D at 36, his dentist called the imaging remarkable progress. George said, "My whole life, I thought I just had soft teeth. Turns out my teeth were waiting for something they never had enough of." Here's your vitamin D3 protocol. First, get your serum vitamin D level tested. This is a simple blood test, typically covered by insurance when ordered for bone health or immune function monitoring. Ask your physician for a 25-hydroxyvitamin D test. Optimal range for dental health appears to be between 40 and 60 nanograms per milliliter, based on current literature. Second, if you're deficient, supplement with D3 specifically, not D2. D3 is the biologically active form your body uses most efficiently. For adults over 65 with deficiency, doses of 2,000 to 4,000 IU daily are commonly recommended, but work with your physician on your specific dose. Third, take D3 with fat. It's a fat-soluble vitamin, and absorption is significantly enhanced when taken with a meal containing fat. Taking it with water alone reduces absorption by up to 30%. Fourth, get some direct sunlight on your skin when possible. Even 10 to 15 minutes of midday sun exposure on arms and face without sunscreen produces meaningful vitamin D synthesis. This isn't about avoiding sun protection broadly. It's about strategic short-duration exposure. Fifth, pair D3 with magnesium. Magnesium is a cofactor required to convert vitamin D into its active form. Without adequate magnesium, supplemental D3 is partially wasted. Magnesium-rich foods include dark leafy greens, pumpkin seeds, black beans, and dark chocolate. One critical note: vitamin D toxicity is rare but possible with very high doses over extended periods. Stay within the upper tolerable limit of 4,000 IU daily unless under physician supervision. And always retest after 90 days of supplementation to verify your level is moving in the right direction. Now here's where it gets really interesting, because vitamin D3 gets the minerals moving. But there's a second vitamin that decides where they end up, and this second vitamin is perhaps the most under-discussed nutrient in all of preventive dentistry. Number 3 will connect things in a way that you won't forget. Number 3, vitamin K2, the mineral rooter. This is the missing piece that most dentists, most physicians, and honestly most nutrition experts haven't fully integrated into their clinical thinking yet. And that's not criticism. The research on K2 is recent enough that it simply hasn't made it into mainstream dental education yet. Here's the problem K2 solves. Calcium is essential. Your body needs it for bones, for teeth, for nerve function, for muscle contraction. But calcium deposited in the wrong place causes serious problems. Calcified arteries, kidney stones, calcified plaque. The calcium that should be building and repairing hard tissues like teeth and bones ends up in soft tissues where it causes damage. A groundbreaking 2024 paper published in the Journal of Bone and Mineral Research, drawing on cohort data from the Rotterdam study involving 11,000 adults tracked over 15 years, identified the mechanism with precision. Vitamin K2 activates a protein called matrix GLA protein, or MGP, which specifically inhibits calcium from depositing in soft tissues. It also activates osteocalcin, a protein that pulls calcium into bones and teeth. Without adequate K2, vitamin D3 drives calcium absorption but has no guidance system for where that calcium goes. With adequate K2, the calcium is actively routed away from arteries and toward teeth and bones. Think of D3 as the delivery truck and K2 as the GPS system. D3 picks up the calcium and puts it in circulation. K2 directs it to the right address. Here's why this matters specifically for remineralization. A 2023 clinical trial from the University of Ghent, Belgium, followed 300 adults with early dental lesions for 18 months. One group received vitamin D3 alone. One group received vitamin D3 combined with vitamin K2 MK7, the most bioavailable form. The D3 only group showed modest remineralization in 38% of lesions. The D3 plus K2 group showed remineralization in 67% of lesions, nearly double the rate, same D3 dose, just with the routing system in place. And here's what's frankly stunning about this. The researchers also measured arterial calcification scores in both groups. The D3 only group showed no change. The D3 plus K2 group showed a measurable decrease in arterial calcium deposits. The same intervention that improved their teeth was simultaneously clearing calcium from their arteries. Let me tell you about Margaret Worthington, a 73-year-old retired pharmacist from Denver, Colorado. Margaret had been diligent about calcium supplementation for bone health for years. She took 1,200 milligrams daily, as her gynecologist had recommended after menopause. She brushed with fluoride toothpaste, saw her dentist every 6 months. But she was experiencing progressive dental deterioration, root sensitivity, early-stage lesions appearing each year. And at her annual cardiologist visit, she was told her coronary artery calcium score had increased again. Her cardiologist wasn't alarmed yet, but was watching it. Margaret's intervention: we maintained her calcium intake but shifted the source more toward dietary calcium, reduced her supplement dose to 600 milligrams, and added vitamin D3 at 3,000 IU and vitamin K2 MK7 at 180 micrograms daily. At 12 months, her new cavity rate dropped to 0 for the first time in 5 years. At 18 months, a follow-up dental radiographic comparison showed reversal of 2 early lesions, and her cardiologist's coronary calcium score for the first time in 6 years went down rather than up. Margaret, who understood pharmacology well, was quiet for a moment when I showed her the comparison. Then she said, "I had the calcium all along. I just had the routing completely wrong." Here's your vitamin K2 protocol. First, aim for 100 to 200 micrograms of K2 MK7 daily. MK7 is the form with the longest half-life in the body, meaning it stays active for over 72 hours after a single dose. MK4, another common form, is cleared within hours. Second, take K2 with a fat-containing meal. Like vitamin D3, K2 is fat-soluble and requires dietary fat for absorption. Third, pair it directly with your vitamin D3. Many supplement formulations now combine D3 and K2 in a single capsule. This is convenient and ensures you're taking them together. Fourth, consider dietary sources as well. Natto, a fermented Japanese soybean, is the richest dietary source of K2 MK7 by far. Hard and soft ripened cheeses like Gouda, Brie, and Edam contain meaningful amounts of K2. Egg yolks and chicken liver also contribute. Fifth, if you take warfarin or any anticoagulant medication, absolutely speak with your physician before adding K2. K2 can interact with blood thinning medications and requires careful monitoring and possible dose adjustment. One critical note: if you're taking calcium supplements, this information should prompt a serious conversation with your doctor about whether you need to adjust your protocol. The evidence increasingly suggests that calcium supplementation without adequate K2 may be counterproductive and potentially harmful to cardiovascular health. Now, we've talked about managing the acid environment. We've talked about supporting the saliva. We've talked about the two vitamins that make mineral routing possible. Number two is the compound that actually fills the holes. And this is where I want to spend some extra time because the distinction between what this does and what conventional dental products do is one of the most important things in this entire video. Number two, hydroxyapatite, the compound your teeth are actually made of. Let me start with a number, 96. That's the percentage of your tooth enamel that is composed of a single mineral compound called hydroxyapatite. It's a calcium phosphate crystal. Specifically, its chemical formula is calcium 10 phosphate 6 hydroxide 2. Your teeth are essentially a carefully organized crystal structure, one of the hardest substances in the human body, built almost entirely from this one mineral. When demineralization occurs, hydroxyapatite crystals are dissolving. The lattice structure that gives enamel its hardness and acid resistance is losing its building blocks. What remineralization does, at its most fundamental level, is replace those specific crystals. This is why the research on hydroxyapatite toothpaste and remineralizing products has been so compelling. You're not applying a foreign substance. You're applying the exact mineral the tooth is made of. A 2023 systematic review published in the British Dental Journal analyzed 24 randomized controlled trials comparing nano-hydroxyapatite with fluoride for remineralization of early dental lesions. The meta-analysis found nano-hydroxyapatite was equivalent or superior to fluoride in remineralizing early enamel lesions in 17 of the 24 studies. In 7 studies specifically examining lesion depth reversal, hydroxyapatite outperformed fluoride, and a 2024 head-to-head trial from Okayama University in Japan, considered by many researchers to be the most rigorous direct comparison published to date, followed 430 adults with diagnosed early enamel lesions for 2 years. The nano-hydroxyapatite group showed 23% greater lesion reversal than the fluoride group. And critically, the mechanism explains why. Fluoride works by converting hydroxyapatite into fluorapatite. That's a chemically different crystal, harder and more acid resistant. But it's not the original material. It's like painting over damaged wood instead of replacing the wood. The surface gets harder, but you haven't filled what was lost. Nano-hydroxyapatite, because its particle size is engineered at the nanometer scale, can penetrate into the enamel microchannels where dissolution occurred and actually crystallize in those spaces. It's replacing the lost material with the same material. I want to be honest here because I think the nuance matters. The research isn't unanimously in favor of hydroxyapatite over fluoride for all situations. Some studies show fluoride outperforms in certain conditions, particularly in very high caries risk populations. The smartest approach, and this is increasingly the clinical consensus, is that these tools are complementary, not competitive. But for people looking to maximize remineralization of early lesions, nano-hydroxyapatite is now considered a first-line option by most evidence-based researchers. Let me tell you about Patricia and Edwin Chu, a married couple, both in their late 60s, from Seattle, Washington. They came in together, which I mention because what happened with them illustrates something fascinating about why the same environment can produce different outcomes. Patricia had been using a fluoride toothpaste her whole life, meticulous brusher, good diet, low snacking frequency. But she had persistent early lesions on 2 rear molars that had been monitored for 3 years without improvement. Edwin, by contrast, had switched to a nano-hydroxyapatite toothpaste on his own after reading about it online 14 months before we saw them. He'd been skeptical but persistent. His dental radiographs told a clear story. The 2 early lesions his previous dentist had flagged were no longer detectable. We switched Patricia to a Nano-Hydroxyapatite toothpaste and maintained everything else identical. At her 8-month follow-up, one of the two lesions showed measurable remineralization. At 14 months, both had reversed. Patricia said, "I spent 30 years being told that fluoride was the best thing for enamel. I'm not angry, exactly. The science just moved." Here's your hydroxyapatite implementation protocol. First, switch your toothpaste. Look for products with nano-hydroxyapatite as an active ingredient. The concentration should be at least 8 to 10% nano-hydroxyapatite. Reputable brands now formulate specifically for remineralization. You can find these at most health food stores and online retailers. Second, brush technique matters more than you think. Use a soft bristled brush, not medium or hard. Brush for 2 minutes using gentle circular motions. Aggressive scrubbing removes softened enamel crystals rather than depositing minerals. This is a case where more pressure is actively counterproductive. Third, don't rinse immediately after brushing. This is genuinely counterintuitive to most people, but rinsing after brushing washes away the hydroxyapatite that's beginning to integrate into enamel microchannels. Spit, but don't rinse. Give the minerals 10 to 15 minutes to begin working. Or if rinsing is important to you for freshness, wait 30 minutes before rinsing with water. Fourth, consider a hydroxyapatite-containing mouthwash or remineralizing paste for additional exposure. Some products are designed specifically for spot application on white spot lesions. These can be applied directly to the early cavity area after brushing. Fifth, consistency is non-negotiable. A 2024 adherence study from the University of Michigan confirmed that remineralization rates in clinical trials are strongly correlated with product use consistency. Twice daily, every day, the cumulative mineral deposition from consistent application is what produces the reversal seen in the imaging studies. One critical note: if you're in a community without water fluoridation and you have children, please discuss the hydroxyapatite versus fluoride decision with a pediatric dentist specifically. The evidence base for children has some important nuances, particularly regarding developing teeth, that differ from the adult remineralization literature. And now we've arrived at number one, the foundational insight that makes everything else work. The one piece that ties together acid control, saliva quality, vitamin routing, and mineral delivery into a unified daily practice. And honestly, it's simpler than you might be expecting. Number one, the pH recovery window. Using time itself as your healing strategy. Here's the truth that the research makes impossible to argue with. Every single intervention we've discussed, the mineral supplementation, the vitamin D3 and K2, the hydroxyapatite toothpaste, all of it, works only when your mouth has time to be in a neutral or alkaline state. Remineralization is a pH-dependent process. It cannot occur below pH 5.5. At pH 7 and above, it occurs at maximum efficiency. This means that even if you have perfect vitamin levels, perfect saliva, and the best hydroxyapatite toothpaste available, none of it will produce significant remineralization if your mouth is spending most of the day in the acid zone. A 2024 landmark study from the University of Manchester, the largest of its kind, followed 3,200 adults for 4 years. Participants were divided based on their calculated daily pH recovery time, meaning the cumulative hours per day their mouth pH was above 5.5. The results were unambiguous. Adults whose mouths spent more than 16 hours per day in the neutral to alkaline range showed remineralization rates 4.3 times higher than those spending fewer than 12 hours in that range. 4.3 times higher, with the same diet quality, the same hygiene. The difference was time. Think about what that means practically. 8 hours of sleep, no eating, saliva flowing, pH neutral, perfect healing conditions. Your body is doing this for you every night, assuming you're not eating in bed and you don't have severe dry mouth. The question is, what's happening in the 16 waking hours? Let me tell you about Robert and Linda Okonkwo from Houston, Texas. Robert was 69 and Linda was 72. Both had similar lifestyles, similar diets, similar vitamin levels. Both took the same medications. But Robert had half the cavity rate of Linda despite nearly identical circumstances. Their dentist called it a mystery. It wasn't. When we did a detailed dietary timeline with both of them, the difference emerged. Robert was retired but structured. Breakfast at 7, lunch at noon, dinner at 6, coffee in the morning, water the rest of the day. He described himself as not a snacker. Between meals, his pH was recovering fully. Linda loved her afternoon tea ritual. Chamomile at 2, usually with a small sweet. She'd also recently developed the habit of keeping mints in her pocket for fresh breath after meals. Sugar-free mints, so she thought they were harmless. Most sugar-free mints contain citric acid as a flavoring agent, bringing pH down almost as effectively as sugar. Her tea plus mint habit meant her mouth was spending an extra 3 to 4 hours daily in the acid zone compared to Robert's. We removed the mints, shifted her tea ritual to immediately after lunch rather than a separate afternoon event, and added a calcium-rich rinse before bed. Her cavity rate dropped by over 80% in the following 12 months. Linda looked at the data and said, "I was being so careful. I just didn't know that the careful things were the problem." Here's your complete pH recovery protocol, which is really the master framework that everything else supports. First, define your acid windows. Aim for no more than 5 distinct eating occasions per day. Breakfast, a mid-morning option if truly needed, lunch, afternoon snack if needed, and dinner. Outside those windows, water only. This simple framework gives your mouth recovery time between every acid event. Second, use the post-meal protective sequence. After any meal or snack, rinse with water, chew xylitol gum for 5 minutes, and if possible, eat a small piece of hard cheese to drive pH toward alkaline quickly. This sequence, taking less than 10 minutes, can cut your post-meal acid exposure time approximately in half according to the Manchester data. Third, take your hydroxyapatite toothpaste at night, just before bed. Your overnight sleep period is your longest uninterrupted remineralization window. Going to bed with a fresh application of Nano-Hydroxyapatite gives those minerals 8 hours of neutral pH conditions to integrate into enamel. This is arguably the single highest leverage habit in this entire protocol. Fourth, add a 5-minute morning oil pulling session. I want to be transparent here. The evidence on oil pulling is not as strong as the other elements in this protocol, and I acknowledge that. But a 2023 systematic review found modest evidence that oil pulling with sesame or coconut oil reduced Streptococcus mutans colony counts meaningfully. The theory is that oil mechanically removes biofilm from areas that brushing misses, reducing the acid-producing bacterial load for the first few hours of the day. The research isn't settled, but the risk is essentially zero, and the potential upside is real. Fifth, and perhaps the most powerful single habit in this entire list, drink a glass of calcium-fortified milk or calcium-rich mineral water before bed. This loads your saliva with calcium and phosphate during your longest recovery window. Milk has a pH of around 6.7 to 6.8, slightly acidic but nothing like soda or juice, and its calcium content significantly elevates the mineral saturation of your saliva. The timeline for this complete protocol working together. Within 30 days, you should notice reduced cold sensitivity as enamel microchannels begin to fill. Within 60 to 90 days, white spot lesions may visibly begin to look glossier and less chalky. At 4 to 6 months, your dentist should be able to document measurable improvement on radiographic imaging of early lesions. Full remineralization of an early lesion to the point of radiographic invisibility typically takes 6 to 18 months, depending on lesion depth and your individual mineral metabolism. One case study I want to share here because it's a complete picture of the whole protocol working together. Thomas and Grace Eisenberg, both retired educators from Chicago, Illinois. Thomas was 76. Grace was 73. Thomas had avoided the dentist for 7 years out of financial anxiety after losing dental coverage at retirement. When he finally came in, he had 11 lesions flagged, 3 of which were borderline for drilling and 2 that had progressed beyond the remineralization window and needed restoration. But 6 of those 11 were early-stage white spot lesions. His dentist wanted to schedule fillings for all of them. Thomas asked for 3 months to try a structured remineralization protocol before proceeding with the non-urgent ones. His protocol: vitamin D3 at 3000 IU with magnesium glycinate at 300 milligrams daily, vitamin K2, MK7 at 200 micrograms daily, Nano-Hydroxyapatite toothpaste twice daily, no rinsing after brushing, calcium-rich mineral water glass before bed, eating consolidated to 4 occasions maximum per day, sugar-free xylitol gum after meals, twice weekly fluoride varnish application at the clinic for the first 2 months. At his 3-month re-examination, 4 of the 6 early lesions showed measurable remineralization. At 6 months, 5 of the 6 had reversed completely on imaging. 1 remained, smaller, but still present. Thomas came in for that 6-month appointment with Grace, who had been following the same protocol supportively. The dentist pulled up both sets of imaging side by side. Thomas's reversal was documented, and Grace, who had started the protocol proactively, showed 0 new lesion formation and measurable reduction in 3 previously monitored watchful areas. Thomas said, "I was scared to come back to the dentist for 7 years. The first time I go back, I find out my teeth can heal. Why isn't everyone told this?" That question deserves a real answer. It's not a conspiracy. It's a combination of medical education lag, the fact that fillings are an evidence-based and sometimes necessary intervention, and the reality that a remineralization protocol requires patient engagement over months in a way that a single appointment filling does not. But the information exists, and now you have it. Now I want to take a moment here before we pull everything together. We've covered a lot of ground today. 7 steps built on real science, from the mechanism of acid dissolution to the vitamin routing system, to the specific mineral that fills enamel back in. It's a lot to hold. But I want you to hear something clearly. You don't need to do all of this at once. You don't need to be perfect. And you are absolutely not too late. The research keeps showing something that gives me genuine hope every time I read it. The oral environment is highly responsive. Unlike some body systems where damage accumulates irreversibly over decades, enamel in its early stages of compromise responds quickly to the right conditions. The Manchester study found statistically significant remineralization beginning within 4 to 6 weeks of protocol initiation in participants who had been losing mineral content for years. Your teeth have been waiting for the right conditions. You can create those conditions starting today. Remember Thomas from Chicago? The man who avoided the dentist for 7 years out of fear? I heard from him about 4 months after that 6-month appointment. He sent a photo of himself at his granddaughter's birthday party, smiling widely in the picture, something he'd apparently stopped doing years ago because he was self-conscious about his teeth. He wrote, "My dentist said I'm the first patient she's had who came in with 11 cavities and left with 5. I'm not going to stop." That's what this is about. Not just the biology, the life you get back when you stop accepting decline as inevitable. This community, the people watching this, is made up of individuals who refuse to hear "that's just aging" and accept it. People who look for the mechanism, look for the evidence, and then act on it. That's you. You've been here for this entire video. That matters. I want to tell you what's coming next because I think you'll want to stay close. Next week, we're going deep on the root sensitivity question, specifically what's happening biologically when your teeth hurt with cold and why the standard dental advice is incomplete. The research I found changes the treatment approach entirely. After that, a video specifically on medications and oral health that I've been working on for 2 months. Over 400 medications affect your teeth, and almost nobody is warned before they're prescribed. This video could genuinely save your dental health. And every week, I'm translating the latest dental and nutritional research into the kind of language you can actually use. No jargon walls, no unnecessary complexity, just what the science shows and exactly what to do with it. If you want to catch those, tap subscribe and the bell. That way, you'll know the moment they're available. Before you go, one request. Tell me in the comments which of these 7 steps surprised you most. And if you've already been doing any of them, I genuinely want to know. Your experience is valuable, not just to me, but to the thousands of other people who read these comments looking for hope and practical evidence. You just invested 45 minutes in understanding how your body works and how to work with it. That's not nothing. That's a meaningful act of care for yourself. Take care of your teeth. Take care of yourself. I'll see you in the next one.